Good afternoon and welcome to today's Webinar Wednesday, sponsored by the North Dakota Brain Injury Network. My name is Sarah Ring. I am a speech language pathologist at Sanford Health in Fargo, North Dakota. I have worked in the field of brain injury rehabilitation for 27 years and have had the privilege of working with hundreds of individuals across the lifespan and across the continuum of care following traumatic brain injury. I use the scale that we're going to be talking about every day. I can't talk about brain injury without using this scale. And so I hope that if you're hearing about this scale for the first time, that you are intrigued and consider implementing this in your brain injury team. If you are familiar with the Rancho levels and perhaps have gotten a bit lax as far as their use, I hope that this webinar series does encourage their use. And so let me share my screen with you. Let's do this. All right. So my intention today is to provide an overview of the scale as far as its inception and its use, and then really dive a little bit deeper into the first three levels of the scale, which I refer to as the early phase of recovery, Rancho levels 1, 2, and 3. We will be reviewing each of those levels specifically, providing behavioral characteristics within those levels, strategies for interacting or stimulation during those levels, and also offer you a little video illustration to reinforce the information in our slides today. Our objectives are threefold: that participants be able to describe 3 practical uses for the scale, that participants will be able to define behavioral characteristics of individuals at those Rancho levels 1, 2, and 3. And then finally, that participants will list 3 strategies for stimulation for individuals at those levels 1, 2, and 3. There are particular things that you as a family member, as a provider, can do when interacting with individuals in this early phase of recovery that actually promotes recovery after TBI. And so I must mention that we are focusing on the population of TBI, or traumatic brain injury, when using the Rancho Los Amigos scale. This scale is not applicable for individuals who sustain non-traumatic brain injuries. So for individuals who you see who sustain a stroke, brain infection, brain tumor, anoxic brain injury, this scale is not applicable, should not be used with that population, but rather only individuals who sustain traumatic brain injury. And so to clarify the population for which we're talking today, TBI is defined by the Center for Disease Control and Prevention as defined as a blow or jolt to the head or a penetrating injury that disrupts the function of the brain. We certainly know that not all blows or jolts to the head result in a TBI. You may or may not know that the severity of a TBI can range from mild to severe, and we're going to talk about that on our next slide. Finally, TBI can result in short or long-term problems with independent function. All right, the current practice is to classify TBIs as either mild, moderate, or severe in nature. And the Rancho levels span across the severity levels. And we will certainly talk about that a little bit later. But for clarification, those mild TBIs result in 0 to 30-minute loss of consciousness for individuals. So individuals may or may not experience loss of consciousness. They may have an alteration of consciousness from a moment, that dazed feeling, from a moment up to 24 hours. Individuals who experience mild traumatic brain injury may or may not experience what we term post-traumatic amnesia, or the difficulty or inability to learn new information after a TBI. We will also be reviewing what is called the Glasgow Coma Scale, or the GCS, on your slide. That is an assessment tool that is often utilized in the field by EMTs, in the emergency department, by those medical providers who are first assessing an individual following a TBI. And that individual is then given a Glasgow Coma Scale score. Individuals with mild injuries are given scores that range from 13 to 15. In contrast, individuals who are diagnosed with moderate traumatic brain injuries often have evidence of their injury on neuroimaging. So things like a CT scan or an MRI will certainly more than likely show some sort of abnormality or evidence of their brain injury. Individuals with moderate TBI experience a loss of consciousness that ranges from 30 minutes to greater than 30 minutes to less than 24 hours. Similarly, their post-traumatic amnesia ranges from greater than 1 to less than 7 days. And those initial Glasgow Coma scales range from 9 to 12. And then finally, our severe TBIs most certainly show up on neuroimaging. These individuals experience loss of consciousness greater than 24 hours and post-traumatic amnesia greater than 7 days. Initial Glasgow Coma scales for these individuals with severe type injuries range from 3 to 8. There are several factors that influence an individual's prognosis following TBI. Probably most significantly are location of injury and severity of injury. Understanding what parts of the brain were damaged and injured following injury helps providers understand what potential consequences an individual may experience. Severity of injury. Certainly, we know that severity does not equal function, right? So we like to say that because we know that an individual who sustains a mild traumatic brain injury doesn't necessarily just have mild consequences from that injury. But certainly understanding the severity of an injury helps as we determine prognosis for an individual. It was once thought that individuals who sustained their brain injuries at a younger age were better off, that they would recover more rapidly with fewer long-term consequences. And we certainly know that that is not the case now. We know that for kiddos who sustain their injury at a young age, they most certainly experience long-term consequences related to physical, cognitive, behavioral functioning when their developing brains are injured at such a young age. The duration of post-traumatic amnesia has also emerged as a strong measure of injury severity after TBI. So we know that the longer an individual sustains that period of post-traumatic amnesia, or that inability to remember or learn new information, the prognosis is less optimal for that individual. Excuse me. There are several factors that an individual may bring to their brain injury that also influences prognosis. So an individual's pre-morbid intelligence level has been identified to influence prognosis. Things such as psychosocial factors, your socioeconomic status, your familial unit and level of support, those sorts of factors can influence prognosis. Pre-existing conditions such as, medical conditions, mental health conditions, pain, headache, sleep issues, all of those sorts of factors can influence recovery after TBI. And finally, does an individual have a history of a previous brain injury? As we consider the role of repetitive injuries and how individuals are 3 to 7 times more likely to sustain a second and third injury after an initial injury. So that prognosis is certainly influenced by repetitive injuries to the brain. So here is a brief overview of the scale, which is termed the Rancho Los Amigos Scale of Cognitive Recovery Revised, or the RLA scale. This scale was initially developed in 1972 at the Rancho Los Amigos National Rehabilitation Center in Downey, California. For those of us in the field of brain injury rehabilitation, it's hard to imagine that this wasn't always a thing. But really, the field of brain injury rehabilitation wasn't launched until the 70s and 80s, when individuals started to understand that for a variety of reasons, survivors were surviving brain injuries, and providers wanted to be able to best manage individuals across their course of their recovery. And so this particular team at the Rancho Los Amigos National Rehabilitation Center developed this scale based on an assumption that observing the type and nature and quality of a patient's behavioral responses could be used to estimate the level of cognitive functioning across the course of their recovery. Now, this scale was initially had 8 levels, but was revised both in 1974 and finally in 1997, when levels 9 and 10 were added to better reflect those higher levels of recovery. This particular scale offers levels presented as behavioral descriptions in a narrative form that helps the rater decide which level that a particular patient is presenting at as far as the observable behaviors. Now, there are several practical uses for this scale. I feel like I'm kind of doing a sales pitch because I really do feel like it's hard to talk about brain injury without talking about the Rancho levels. So I hope that you can appreciate the fact that a standardized tool or common language allows healthcare professionals to better understand a patient's abilities, their impairments, and be speaking the same language. Everyone is on the same page. The awesome thing about this scale is that it also facilitates communication among team members. Whether you are a speech language pathologist or a physical therapist or a social worker, you are able to identify an individual's level of functioning based on your interaction with that individual. And as the team comes together, that conversation, that communication about observable behaviors and how an individual is falling on that scale can help predict outcomes and predict recovery. The communication also facilitates rehabilitation planning. We know that recovery after brain injury follows no particular timeline, and that planning needs to be flexible. And this particular scale guides rehabilitation planning and allows individuals to identify how to best interact with individuals at various levels within the scale. Finally, this scale evaluates recovery after TBI. It allows for an individual, a survivor, to consider how far they've come, even when it's hard to remember those initial stages of recovery. The scale offers behavioral descriptions as an individual accepts and moves forward as a survivor of brain injury. Research has found that this use of this scale has very high inter-rater reliability. That means that if my team members and I are all looking at the same patient within a relatively similar period of time, that we will more than likely be very similar in at the level in which we are giving that individual by simply observing behavior and using the scale terminology. So this slide offers you simply the labels of levels 1 through 10 on this scale. And I have color-coded them to help us conceptualize early phase of recovery, which I have here in yellow, middle phase of recovery, which I have in purple, and late stage or phase of recovery in blue. We are certainly in this three-part series going to be addressing all levels of recovery, but today's topic is focused specifically on Rancho levels 1, 2, and 3. This is again termed the early phase of recovery, in which individuals at Rancho level 1 exhibit no response. Individuals at Rancho level 2 exhibit generalized response, and individuals at Rancho level 3 exhibit localized response. So you can see a gradual progression, gradual recovery as we move even within this early phase of recovery. Now, as I mentioned earlier, the Rancho Los Amigos scale revised is often used in conjunction with the Glasgow Coma scale to provide an early assessment of cognitive functioning in individuals following brain injury. So again, this scale more specifically is looking at behavior. We're looking at eye movement. We're looking at orientation, and we're looking at an individual's ability to follow commands. So eye responses, verbal responses, and motor responses. So a score is given within each of those behavioral areas. And as you recall, a score of 13 to 15 would be classified as a mild TBI. A score between 9 and 12 correlates to a moderate TBI. And a score of 3 to 8 correlates to moderate TBI, or excuse me, severe TBI. I included this scale because while it's different from the Rancho scale, it is helpful in evaluating a patient's recovery, particularly at that initial time of injury. We're going to move forward and talk a little bit more specifically about these early stages. Rancho level 1, or no response. At this stage, an individual appears to be in a deep sleep with their eyes closed. These individuals are in coma. And although the individual may be restless, he or she will not or is unable to respond to stimuli. In other words, sounds, sights, touch, or movement. Individuals at level 1 are unable to follow commands. They are unable to communicate and unable to respond to pain. So these individuals require total assistance from a medical team. But it's important to remember that even at level 1, it's in this coma when the brain is starting to heal itself. And so we'll talk about some ways, again, that you can promote recovery even in these periods of time in which responses are limited and non-purposeful. At Rancho level 2, or generalized response level, individuals remain individuals require total assistance. Their responses may be more frequent, but inconsistent, delayed, or not specific to a particular stimuli or purposeful. The individual still may be asleep most of the time, but they may wake slowly to noises or movement. They may be able to do things spontaneously, such as open their eyes or respond in general to pain, a generalized response. They may have periods of wakefulness, but they are not aware of their surroundings. Individuals are unable to communicate, unable to follow commands, and we are certainly not able to determine the level of cognitive or motor impairments to any comprehensive degree at Rancho level 2. I'm going to stop sharing my screen and attempt to share a video clip from a video clip of an individual at Rancho level 2. These clips are, I found these clips from an educational tool through Craig Hospital in Colorado. And so I'm hoping that my screen is going to let me do that. Let's take a look. Let's do this, actually. Let's do this. Go. Oh, here we go. All right. So I'm just going to play about a minute, little over a minute of this. Again, this individual is at Rancho level 2. Notice what you see. What sort of behaviors are you observing? Okay, so that video clip, I think, clearly illustrated the idea that that individual, his eyes were open, he was awake, but he was unable to communicate, unable to follow commands, and the responses that you observed were somewhat generalized and delayed at times, rather than a specific response to the pain or tactile stimulation that she was offering. You also likely observed the increase in heart rate or breathing. You noticed the reflexive chewing. Again, very low level responses, but certainly improvement compared to an individual at Rancho level 1. Individuals at Rancho level 3 or localized response level remain under the need of total assistance. Individuals are more awake for longer periods of time during the day. Individuals may exhibit an ability to respond to stimuli and to move their limbs and their body more often. And those responses may be more specific to the stimuli, but they still may be delayed or inconsistent. Individuals may be more likely to exhibit a typical response to pain rather than that generalized response of increased breathing and intense reflexive chewing that we saw at level 2. Individuals at Rancho level 3 exhibit improved focused attention, their ability to focus their attention even briefly on a visual information. Following verbal commands may be difficult, as is one's ability to verbally communicate. I'm going to show you a clip of an individual at Rancho level 3. Here we go. Okay. This individual is at Rancho level 3. Hang on, it's coming. Just a minute. Here we go. Okay. Again, I think a very clear illustration of the behaviors that are typical of that Rancho level 3. We saw that individual awake. We saw that he could focus his visual attention and even participate in a brief task, despite his inability to verbally communicate. And his ability to follow those verbal commands certainly decreased over time. But increased responses means increased brain recovery, right? So certainly his brain was doing a lot of really awesome things there. And I think it's easy to see how different the definitions of level 1, level 2, and level 3 are as identified as indicated by the scale. All right, so whether you are a family member, whether you are a medical team provider, these are the general goals for an individual at that early phase of recovery, those Rancho levels 1, 2, and 3. It's important to prevent sensory deprivation. We certainly don't want to prevent any sensory input to the individual. There are just certain ways in which it's best to go about doing so, and we'll talk about that. Secondly, the goal is to increase arousal or one's ability to stay awake and be awake, be present, and increase their attention. Thirdly, we want to decrease confusion. What a frightening thing to wake up in a hospital and not be aware of why you were there, where you are, what's happening. So there are things that we can do as family members or providers that can also help decrease confusion. My PT colleagues and OT colleagues help an individual maintain mobility and prevent things like contractures and those types of things. OT and PT are generally active with passive range of motion, again, to minimize those complications with mobility once an individual continues to progress through these Rancho levels. And finally, education. We are educating family for whom brain injury may be something extremely novel and scary. We are educating each other as team members as to our observations and what types of interactions or stimuli promote best responses, which indicate recovering brain. Okay, so we can consider things such as environmental modifications. I think what I want to do is I want to just jump to this slide. My next 3 slides give specific information about interacting with an individual, suggestions for stimulation when interacting with an individual at Rancho levels 1, 2, and 3. Depending on the facility in which the patient resides, there may be what's termed low stim guidelines. Our particular facility uses that system. That means that there are certain conditions within the environment that need to be managed in order to provide some stimulation, but not too much stimulation for an individual in the early phases of recovery. So it's important to keep the room calm and quiet. It's important to keep your comments short and simple. For example, instead of saying, "Can you turn your head and look towards me on your right?" you might simply say, "Look at me." Again, keeping your comments short and simple. Those low stim guidelines often limit the number of visitors in a room at a particular time. And certainly, it's encouraged that only one person be speaking at a time. It's important to explain to the patient what you're about to do. For example, "I'm going to hold your hand," or "I'm going to put on the blood pressure cuff," or "I'm going to change your blankets," before you're doing the action, and allowing the individual a little bit of time to potentially process that information so that a particular stimulation or whether it's tactile or temperature isn't startling and potentially agitating for that individual. It's important to talk in a normal tone of voice. There's no need to yell. There's no need to speak directly into their ear. The individual can hear you. Assume that individual is hearing what you're saying. So choose the topics about which you speak as if the individual can hear you and understand you. We talked about that goal of decreasing confusion. So it's very important that each time you see the patient, each time you approach the patient, tell them who you are and provide them orientation information. Hi, Johnny. It's Sarah, your sister. Today is Wednesday. It's October 2nd, 2024, and it's about 1:30 in the afternoon. We're in Fargo at the hospital. Clarifying that information every time you interact with that individual. At this stage of recovery, they are not able to remember new information. So each time, it's as if you're telling them for the first time. I mentioned earlier, assume he or she can hear you. So be careful what you say in the presence of the patient. I mentioned not yelling when communicating with the patient. Asking yes/no questions rather than open-ended questions that could potentially require a lengthy response. Move and speak in a calm, quiet manner. ICU rooms are sometimes scary places to be, and individuals, visitors, family members have a lot of emotions about seeing their loved one in such a state. And so it would be easy to potentially speak loudly, move quickly, but in contrast, an individual will respond best when we are speaking and moving in a calm and quiet manner. It's important to offer rest breaks, as individuals with brain injury tire easily. You could see that with that individual who was Clint, who she was asking to say, look at the ball, look at the cup. You could see that he did okay for a little bit, and then you could see he kind of just looked off to the side. His brain tired quickly. And so short visits, short conversations, short stories are important. And an individual may respond best to that. Consistency with routine and staff. The brain likes consistency. It likes routine. And so by providing consistent staff, by visiting at consistent times, those things may promote recovery. Finally, if you are a family member, bringing in favorite pictures or belongings and talking about those things to an individual in the early phases of recovery. They're not able to respond. They're not able to verbally communicate. But again, assume that they understand, assume that they are listening, and talking about things of high interest often work the best. Even music that the patient would enjoy. High interest music for short periods of time. As a family member, healthcare providers encourage you to consider self-care. We know you want to be in the ICU. We know that you want to support as best as possible. And there may be jobs, there may be tasks that the medical team will ask you to assist with. Looking for those consistent behaviors and documenting those in a notebook, that is important information for that individual's medical team. And so consider using a notebook or a diary to track behaviors that are observed as you are visiting. Some of those observations may be non-purposeful movements, but eventually the individual will be able to exhibit more purposeful and consistent behaviors, and having someone document that is very, very valuable to the medical team. I felt like this particular webinar may be a good place to just briefly talk a little bit about disorders of consciousness. On this particular slide, you see 3 generally accepted levels of disorders of consciousness. So an individual experiences an initial injury, is in coma, potentially experiences a vegetative state and minimally conscious state. It is estimated that 315,000 persons are living with disorders of consciousness in the US, with the majority of those individuals in minimally conscious state. Let me illustrate for you what that means as we differentiate these terms. So individuals in coma, as we saw, particularly in level 1 and 2, have impaired arousal and awareness. But we know that coma generally resolves in 2 to 4 weeks. For individuals who do not experience or do not emerge from coma, those individuals are classified in vegetative state, where they may have some level of arousal, but no awareness, and remain in that state anywhere from months to years. And finally, minimally conscious state, individuals may have arousal. They may open their eyes spontaneously. They may respond to stimulation appropriately, but the awareness fluctuates. And this particular duration lasts from months to years for these individuals. I wanted to conclude today as we talk about the Rancho Los Amigos scale, is that while we talked about Rancho levels 1, 2, and 3 more specifically, that's the beginning of the story. We know, again, that that is where the brain healing begins, and that by the fascinating process of neuroplasticity and brain injury recovery and medical advances and all the things that providers and family members do to help promote recovery, individuals will emerge through those levels. And it's a fascinating thing that the brain can change itself, neuroplasticity. And I love that we have the Rancho Los Amigos scale to help us better define and support individuals across all levels of recovery. Again, this scale helps provide a common language for the entire team. That means the family too. It helps the family understand what is to be expected at this point in recovery. These behaviors are to be expected. It helps the family talk to the medical team. It helps the medical team talk to each other. And it really guides planning. It helps predict outcomes, and it helps evaluate recovery after TBI. Again, this is the first in a series of 3 specific to use of the Rancho Los Amigos scale of cognitive recovery revised. Our next session will focus on that middle phase of recovery, or levels 4, 5, and 6. So thank you so much for joining me today, and I hope that you join in for the remainder of our series. Have a great rest of your Wednesday.